I'm Rika Koso. I'm one of the hand and upper extremity orthopedic surgeons at OCR. I started this fall here and joining the group. I'm talking today about innovations in carpal tunnel syndrome diagnosis and surgery. And so just to create a common place of understanding, carpal tunnel syndrome is compression of the median nerve underneath the transverse carpal ligament where it enters into the hand. And so patients will report a painful burning sensation. They've got numbness and tingling in the hand. And they'll commonly talk about how the symptoms are worse first thing in the morning when they wake up. Maybe the symptoms are so bad that it disrupts their sleep. They're trying to shake the hand to wake it up. They have symptoms when they drive. They're dropping things, and it's completely disruptive. Of course, there's a differential diagnosis for this, so patients could have cubital tunnel syndrome, which is compression of the ulnar nerve at the elbow. They could have cervical radiculopathy. Peripheral neuropathy is a common issue that can also be confused with carpal tunnel syndrome, and then obviously brachial plexopathy. And so the reason why some of these other diagnoses can be confused for carpal tunnel syndrome is the overlap in nerve distribution. And so the image on the left shows carpal tunnel syndrome as that yellow shaded area, thumb, index, middle finger, and half the ring finger. Obviously, if you have a patient with a C7 radiculopathy where the index and long finger are involved, it can be difficult to differentiate the two. And of course, we have patients who have both problems, right? So if you think that your patient probably has carpal tunnel syndrome, go ahead and start nighttime wrist bracing. It's low cost, it's low risk. There's a potential it's going to improve their symptoms. However, if you think that they have something else going on, either in addition to carpal tunnel syndrome, or maybe it's not carpal tunnel and you really are concerned about something else, the best diagnostic study would be an EMG and nerve conduction study. Now, what I do in clinic is ultrasound. This is something that differs from my partners. It's just a diagnostic that I like to use. What we do, and I'll show you some slides here about what this looks like, is I take an axial view of the wrist. So I put the ultrasound probe right at the carpal tunnel, and then I slide up and down the wrist, identify the median nerve, and what I'm looking for is the area of maximal swelling just proximal to the transverse carpal ligament. And what I'm measuring is the hourglass deformity. So when the median nerve goes underneath that ligament to get into the hand, it gets pinched, and so its diameter will be smaller. And see, if you go just upstream of that, it'll swell up, and that's the area that you're measuring. And that amount of swelling can be diagnostic for carpal tunnel syndrome. So when I measure the circumference of the median nerve on the ultrasound machine, it'll spit out the cross-sectional area. And if the patient has 10 to 11 millimeters squared cross-sectional area, that's mild carpal tunnel syndrome. If it's 12, it's moderate, and if it's 13 or larger, it's severe. Now, what occurs anatomically is the median nerve will go underneath the transverse carpal ligament, and then it'll split out into its branches that go to the fingers and the thenar eminence. In some patients, it'll start branching early. Most commonly, it'll just be two main branches, so a bifurcated median nerve. If I see that, I just measure both branches, and it's the combined cross-sectional area that I use. And this is just a visual out of the New York Hand and Wrist Center that kind of shows what you're about to see on the ultrasound. So the image on the left are the carpal bones, and they create a little bit of a trough for the flexor tendons and the median nerve to enter into the hand. And the median nerve will always be the most central and superficial structure in the carpal tunnel. And then the image on the right is just a visual representation of that hourglass deformity. So the nerve will be pinched underneath the ligament, and then just upstream it'll swell up. And so this is a visual out of an ultrasound company that shows what you should be looking for, and I'll show you some of my own patient photos after this. But you can see the carpal bones are very hypoechoic with a bright rim. And then the center of your flexor tendons, again, we're just looking at that cross section. And so there'll be sort of a medium hyperechogenicity. And the median nerve is in the center. It's the most hypoechoic, but you can see the fascicles. And so this is how you differentiate it from like a cyst or maybe an artery or vein. And here they took the ulnar artery and shaded it in red. But if you put the Doppler on the ultrasound, obviously you can tell that difference. And then the transverse carpal ligament will be a black structure going over the top. And so this is an example of a patient that I had. You can see the median nerve is darker, but you see those little bright spots of heterogeneity in that. That's the fascicles. And so that white outline is what I measure. And then on the bottom left, that's the cross-sectional area. So this patient has severe carpal tunnel syndrome because their cross-sectional area is greater than 13 millimeters squared. They're at 16 millimeters squared. And then this is just another visual. I think it's very hard to look at just a simple image and understand the anatomy, but when you're doing it dynamically, you're getting essentially a video with your ultrasound, and you can really better understand that anatomy. So ultrasound diagnosis for carpal tunnel syndrome, how good is it? It's equally specific to electrodiagnostic studies for the diagnosis of carpal tunnel syndrome. That being said, an electrodiagnostic study is more sensitive. And so sometimes this is a plus, if a patient has very mild disease, but sometimes it's a negative because there are studies in which there's normal volunteers, they'll do an actual electrodiagnostic study, and some portion of them will be found to have very mild carpal tunnel syndrome, but they have no symptoms. So the only time in which we're doing ultrasound is in people who come to my clinic who already have symptoms. And so I find it not only more helpful, but it's also something I can do in the clinic. I don't have to send them out, wait for them to come back. Now it's been a few more weeks that's passed that they have their symptoms. And also, to be honest, it's not very comfortable getting an electrodiagnostic study or getting these little electroshocks. And so this is a much more comfortable diagnostic for the patient. And then we can make a treatment plan right there in the clinic. And so that's convenient as well. They have also compared ultrasound to MRI, and the measurements are the same. So we don't need to send patients for MRI, and frankly, that'd be a waste of resources. But once you do diagnose the patient, if it's early, mild carpal tunnel syndrome, like I said, go ahead and start that nighttime bracing. I always tell patients you can't just do it kind of on and off and here and there, for a few weeks. You do have to do it every night for at least 6 weeks to hope to notice a difference. I think the question I get the most often, though, is corticosteroid injections. So, when do you do it? Do you do it? There's a really nice Cochrane review of all the literature that indicates that, sure, steroid injection is going to help symptoms. It's better than placebo. It's better than oral steroids. But the symptom relief declines after about a month. And once you hit the 2-month mark, it's not any better than NSAIDs and splinting. And most certainly, 2 injections are not better than 1. And I think in my practice, the main indication for doing a steroid injection would be pregnancy, because that's a temporary physiologic process that's defined by water retention. And once the pregnancy comes to its natural completion, often the carpal tunnel syndrome will go away. And so the steroid injections are just for symptom relief in that setting. And of course, still do the nighttime bracing. For contraindications, that's essentially most everyone else. Really, I find that it just delays their definitive treatment. If they got significant symptoms and you give them a month of relief, then I can't necessarily do a carpal tunnel release right away because an injection will increase their infection risk postoperatively. I also put out a study recently with some colleagues that if you do an injection elsewhere in the hand but near to the operative site, it's also going to increase their infection risk. So I try to avoid doing trigger finger injections before a carpal tunnel release if I know that I'm planning to do that carpal tunnel release in the next 3 months, because I don't want to increase the patient's risk for infection. So that golden time frame is probably about 3 months. Twist my arm and I might do 2, but it's just not ideal because once the patient gets an infection, then they're looking at you. And you're here to guide them and give them that best practices information. So what is the surgery? It's a release of the transverse carpal ligament. You can do it open. It's tried and true. It's safe. It's effective. My most often preferred technique is endoscopic. The incision is in the volar wrist, just proximal to the hand. There's a system that I use that puts a guide just underneath the transverse carpal ligament. I put in a camera, I can see everything, I clean off the ligament, and I cut it in half. This is my surgical setup. There's a few instruments on here just related to closing with some sutures, cutting, and then these are the actual instruments that I use. The Image to the left is a dilator, just creates space for the guide that I put in. There's 2 white-handled instruments that I use to clean up the ligament, make sure that there's no branch of the median nerve that goes through it, because that's an anatomical variant that can make this unsafe if you're not aware and you don't avoid that. And then the 2 T-shaped guides, there's a right and left side guide for the system that I use. And then the image on the right is the blade. And it's a retrograde blade, which means you cut from distal to proximal. Everything in this system is something that can be sterilized and used again, with the exception of the blade, just because it would dull out. And so, again, this is just an image from the system, but on the right-hand side, this is what I'm looking at through the arthroscope. You see these horizontal bright white fibers? That's the ligament. There's nothing else that's going horizontal in the palm. Everything's going longitudinal in order to enter from the forearm into the hand. And in here, you can see sort of this glossy whiteness. That's a synovium over top. And so that's what I'm cleaning off to make sure I get a really good visual before I release it. Now the image on the right in this picture, this is after the release. You can see that the transverse carpal ligament is really a well-defined ligament. This is not an ambiguous structure. On the other side, you're going to see some fat, some connective tissue, and then the thenar musculature. That's what we're not getting into, and I think that's why sometimes the recovery is different for patients, because we're not cutting through that stuff. When you do an open release, obviously you have to dissect down through that just to get to the ligament, and so that would be the major difference between endoscopic and open. So what are the outcomes? This has actually been around for a long time. The first study I found was 1989, and then there's been several comparative studies between then and now comparing endoscopic and open. There's systematic reviews, meta-analyses, mass retrospective studies. They've looked at every aspect of patient care. That's postoperative pain, prescription pain medication, perceived function, how long it takes to get back to work, infection and wound complications, and of course reoperation. And the vast majority essentially are equal. When your carpal tunnel is released, your carpal tunnel syndrome is managed, people feel better, they eventually heal and get back to stuff. So I'm just going to highlight 2 studies that I found were really interesting. This was a matched study. They looked at the Pearl Diver database, over 700,000 charts. They took 300,000 of those and they matched half of those who had endoscopic release to open. And so these are patients with similar amounts of disease, similar demographics. And in this particular study, they just found higher rates of readmission as well as higher rates of infection and wound complications with the open release. And they found fewer complications with the endoscopic, but a higher cost. If you look at this study and you look at other studies, those numbers are going to vary. Some of them will show more complications with one versus another. I really think it settles out overall. But one thing that I wanted to highlight is that they always comment on the higher cost on endoscopic. But that being said, if your patient has a complication, now you've delayed their return to work, now you've incurred more healthcare costs by treating it. And so that upfront cost may settle out. And then another study that I just want to highlight for a moment, this is a prospective randomized trial, endoscopic and open in the same patient. So they took 30 patients that had bilateral carpal tunnel syndrome. They randomized the more symptomatic hand to either endoscopic or open. And then once they healed, they did the other hand with the other technique. They looked at a ton of variables at several intervals during the recovery, 2 weeks, 4 weeks, 8, 12, 14 weeks postoperatively. And they looked at each of these outcome measures. So the patient's demographics, their functional status score, symptom severity score, pain score, sensation, strength, and then just generally their satisfaction. I like the study the most because, again, it shows no difference at any point, but yet somehow 24 out of 30 of those patients preferred the endoscopic and said it was less painful. Now, these are all validated, pain and functional status scores that were used, and they didn't capture that difference, but yet 24 of those 30 patients came back saying, listen, if I ever needed this again, I would have wished they were both endoscopic. So there's something intangible that we're just not capturing, I think, with these data. I recently had a patient where we did endoscopic on one hand and open on the other. The reason for this was we wanted to do some biopsy testing in the first hand for amyloid because the patient had cardiac disease and wanted to know, is this the reason I have cardiac disease? And that's something you can test for when you do a carpal tunnel release by sending some biopsies. And so the patient sent me this email after their second carpal tunnel, and they said, hey, listen, with the first one, it was open. I took 6 tabs of Norco, and then for several weeks, I was alternating ibuprofen and Tylenol. I had pain in my palm for several weeks. I couldn't do push-off because it pushed on where my incision was. And so I couldn't push myself out of the bathtub, and I'm super active. I couldn't do push-ups, and I couldn't ride my indoor bike for at least a month. And so when I saw the patient in clinic after that first surgery, he was like, yeah, I mean, I feel fine. Like, I feel it. It hurts. There's a lot of stuff I'm not doing yet, but I'm okay. And so that's kind of the common experience. Then we do the endoscopic carpal tunnel. He took 2.5 tabs of Norco. He took 1 Tylenol. He iced it for a single day. And then he immediately went back to all of his activities. He was someone who was doing physical therapy for general strengthening, but super avid outdoorsman. He was already biking and kayaking after 24 hours. He had a slight pain in the palm. He said by 10 days he had to really push to try to elicit that pain. And he was riding his indoor bike by a week, and he was lifting heavy stuff and shoveling snow by 2 weeks. So he came back saying, listen, there's no reason I wouldn't do endoscopic again. So I just want to show you guys some examples of what this looks like post-operatively. This is a patient who's 2 weeks post-op. All my images are patients who consented for this to be shown in the talk today. But often it's a little bit red, those sutures. These are absorbable sutures in this example. They're starting to absorb, so it creates a mild amount of erythema, and then there's a little bit of scabbing, which is typical. I essentially tell all my patients, you'll have a bandage for 3 days. After 3 days, take it off, wash your hands, and then anytime that you choose to wash your hands or take a shower, just when you're done, dab a little Vaseline and put a Band-Aid on, and you're good to go. So based on that, by 3 days after surgery, everybody's just doing Vaseline and a Band-Aid. And so this is another example, a little bit of redness, a little bit of scabbing. Overall, it looks great, I think. Another example, a little redness, a little scabbing. Each of those were patients who had the absorbable stitches. I also use non-absorbable, and this is an example. Once the non-absorbable stitches hit that 2-week mark, you'll get a little bit more redness. The skin's healed. The body doesn't want the stitch anymore. It's time to remove it, and that'll go away. And this is another great example of that. A few more examples of the non-absorbables. It's amazing how quickly the human body can heal this incision. And then, in this example I wanted to add, you can get some more redness with the absorbables, a little less common. But again, this is a person just with a little scab and redness, and otherwise that went away by the following week. 6 weeks post-operatively, you can really hardly see it. And the tenderness in the palm where the transverse carpal ligament was cut is long gone by that point typically. And often at this point, I'm just seeing people as needed. But I'll tell them, still got to give it a year for the nerve to recover. So that sensation, the grip strength, give it time. Another example, the 6-week. If you didn't know what to look for, you might not realize that they had their carpal tunnel released at all. And so outcomes, I think the benefit of endoscopic is the incision location. You're not lifting with your forearm, you're lifting with your palms. And so just not putting pressure on the incision is typically less painful. I do tend to find an earlier improvement in post-operative pain. I let my patients go back to work as soon as they want. If they want to go the same day or the next day, it's up to them. I just say no more than 2 weeks off. And then earlier functional recovery. The main downside of endoscopic is simply the upfront cost, but some of that can be really belayed by the fact that a lot of people are going back to work earlier. The other downside is some patients can have a transient neuritis. So if you think about it, that nerve is already under pressure, and I am adding one more thing, which is my camera and instruments temporarily just to relieve the ligament. And so it can transiently irritate the nerve, and that'll improve. So for my algorithm, I prefer to do open in specific settings. That'd be patients who need amyloid testing for their cardiac disease, anyone in whom I plan on releasing the ulnar nerve at the level of the wrist, which is Guillen's canal release. If they have acute carpal tunnel because they just broke their wrist, and so I'm fixing the distal radius fracture, I'm going to manage that carpal tunnel open. And then in any patient who's getting a revision, because it's just not safe to do from a scar standpoint, to do endoscopically. I do tell my patients who have a bleeding disorder or who are on blood thinners, if I can't get a good visual, I'll have to switch to open. So there is a slight increase in me switching from endoscopic to open in those patients. And then this is just an example of a patient that I had with a clotting disorder. Their family made them come in post-operative day 1, and they were like, listen, doc, like, I feel great. I was able to sleep last night. I don't have any burning. I don't have any pain. My numbness is already getting better, but my family wanted you to look at this. And I was like, listen, we expected this. We already know that you bruised. This resolved within 2 weeks. They did great. So for me, it's just, can I get a good visual to do the procedure safely? If I can, I go ahead and I do it endoscopic. And then for endoscopic, for me, that's the vast majority of patients. I really prefer this for laborers. I think it's easier for them to get back to work. And to be honest, they have this thick rind of callus in their palm, of dead, crusted epithelium that isn't the part of the skin that heals together anyway. This is a patient I had show up in pre-op with oil all over his hand because he was working in his garage before he came in. And so I'm just happy not to be cutting through that, and I get to work outside of that area in order to do their release. I also prefer this for anyone who puts regular pressure on their palms. If there's someone who uses a walker, rollator, cane, etc., I think it's a little bit easier in terms of their recovery. And so for that patient who I just showed you the image of, that transverse mark with the marking pen with the 3 dots below it, the 3 dots are me just marking out their palmaris longus. It's just an indicator of their anatomy and helps me center my incision. But that small horizontal purple line that's in the wrist, that's my planned incision. And then the 2 horizontal lines in the palm, that's me showing the patient approximately where their ligament is and where they should expect to experience some tenderness or pain after surgery. So I got to stay out of that oily, crusty area. And these are my dogs. Thank you. Questions? Anyone with any questions before we wrap that up? All right, great. Next up we have one. Oh, go ahead. Oh, no, there's really no. The question was, are there any downsides to having your transverse carpal ligament released? No, you don't lose grip strength. You don't lose anything. I think if we were quadrupeds who walked on all fours, it would have been a more meaningful ligament. But as we're bipedal, it really isn't. Yeah. Any other questions? Yeah, go ahead. Yeah, so the question was, is there sort of an age cutoff at which it's even worth it? Because not everyone has a full recovery. That's a great question. I talk to my patients about that all the time. So if you're 65 and older and you have severe carpal tunnel syndrome, I do not expect your median nerve to have a complete recovery. There is a point of no return, and I tell the patient, listen, this nerve isn't just going to bounce back. But what we do expect to see, number one, and this is the most important reason to do this surgery, is to limit things worsening. Because if that nerve remains under pressure, it will continue to progress, and they'll progressively lose sensation and function, grip strength, and it can be incredibly debilitating. You'll see that the muscle around their thumb begins to atrophy. They can't hold things. And so for me, there's not an age cutoff because everyone uses their hands an unbelievable amount. No matter how old you are, you need to be able to pick up your pills, et cetera. And I can do this surgery, even the endoscopic surgery, awake under local. And so it's no more dangerous in that setting than like a dental procedure. So for me, the goal is to limit progression. But that being said, the vast majority of patients, no matter how old and how long-standing their carpal tunnel syndrome, will notice at least some improvement in their sensation and strength over the course of about a year to a year and a half. And I do tell those patients, if you want to come back in and have a follow-up check, checking your sensation and strength. Happy to do it, but wait at least a year. All right, thank you. So